From Faith Forward Media, this is Healthcare Musings. I'm Dr. Hashem Hasabala. Hey everybody, welcome to Healthcare Musings. Happy to have you with me. Prior authorization. When I was in private practice prior to working in the ICU full-time, I would frequently have to call an insurance company employed physician and get authorization to get a CAT scan. And so I'm a pulmonologist. I would have chronic smokers. There would be nodules found on a previous chest x-ray or a CAT scan. And so the insurance company would make me call their employed physician, discuss the case, and then they would give me permission or authorization to get the CAT scan. It was super annoying. I never lost. I always won because I have a smoker who needs a CAT scan because it could be lung cancer. Still, the process of going through that hoop was super irritating. That's called prior authorization. It's where the insurance company makes you submit their clinical information to the patient, and then they issue authorization to undergo a surgery or procedure or whatever. And most recently, the whole prior authorization process has come under great scrutiny because people accuse the insurance companies of just denying and delaying care so they can save money and maximize their profit. So this was, again, typically done with commercial health insurance, and traditional Medicare, run by the government, did not have prior authorization. Anyone, if your physician feels that a procedure or a test or surgery is medically necessary, they just do it without getting permission from Medicare. That appears to be changing. So I first read about it in the New York Times and about a pilot program that the Centers for Medicare and Medicaid Services recently announced. It was actually announced in the press release was in June of this year, and now it's just now starting to come to light. It's called the WISER program, the Wasteful and Inappropriate Service Reduction Model. So what CMS is going to do, and I'm reading from their website, is they would partner with companies with enhanced technologies, i.e. AI. And what they're going to do is they're going to test ways I'm quoting now, CMS will partner with companies specializing in enhanced technologies to test ways to provide an improved and expedited prior authorization process relative to original Medicare's existing processes, unquote. And so what they're trying to do is to try to root out, quote unquote, waste, fraud, and abuse, right? And so here is what the director of the CMS Innovation Center said in the press release. Low-value services, such as those of focus in WISER, offer patients minimal benefit and in some cases can result in physical harm and psychological stress. They also increase patient costs while inflating healthcare spending. So again, what this model will do is they'll have AI will expedite the prior authorization process, and they are going to submit certain procedures to prior authorization. And I'm trying to find out what kind of procedures they will be. The press release doesn't say. No, never mind. It says here, the WISER model will test I'm quoting, quote, the WISER model will test a new process on whether enhanced technologies, including artificial intelligence, can expedite the prior authorization processes for select items and services that have been identified as particularly vulnerable to fraud, waste, and abuse or inappropriate use. These items and services include, but are not limited to, skin and tissue substitutes, electrical nerve stimulator implants, and knee arthroscopy for knee osteoarthritis. Now, unquote. So now they're going to say if anybody needs these services, they're going to submit to prior authorization. You have to submit, and it's a pilot program in only a few states in the country right now, and they will see, does it save money, and does it reduce inappropriate use of unnecessary studies. What's important is that this model will exclude inpatient-only services. So there are surgeries and things that can only be done on the inpatient level of care. Those won't be included. Emergency services and services that would pose a substantial risk to patients if delayed. So, I mean, that's good, because the fear is, right? The fear is that it's going to expand to everything. So, right, if you want to have a gallbladder surgery, you have to go through prior authorization. If you want, and then everyone's worried, now they're going to subject emergency room visits to prior authorization with Medicare. And this is what they're saying, no, right? So, according to the New York Times article, the people enrolled in traditional Medicare who live in Arizona, New Jersey, Ohio, Oklahoma, Texas, and Washington State will be included in the experiment. It starts in next January and lasts for 6 years. So, and then the denial, if there was a denial, it will be issued by an appropriately licensed human clinician, not a machine. Okay, this is according to the article, and so, and there's a lot of consternation because now traditional Medicare looks to be like it's going the way of Medicare Advantage, which has had a lot of issues and problems, and I deal with it as a physician advisor, where they deny a lot of what seems to be necessary medical care, and so that's the concern. How do I feel about it? I have mixed feelings. On the one hand, like I said in the beginning, it's so annoying to have to call some insurance company employed physician and get permission to do my job as a pulmonologist, right? To get permission to order a CAT scan for somebody who has a nodule, or somebody who has severe COPD, and if they make me do prior authorization to order a pulmonary function test, that's super irritating and annoying, and it's just an extra hoop, and it delays care. There's no question about it. So I get that part, and you worry about the slippery slope, because I really think inevitably they're going to have less procedures, right? And so it's definitely going to save money, and they're going to say, oh, it works great. Let's now expand the prior authorization process to other things. So so on the one hand, it's very annoying and very irritating. On the other hand, if there are procedures and things that really don't have a lot of medical evidence behind them, there's not a lot of good science behind them, and they don't, if subjected to scrutiny, will not be shown to improve outcome, then really are they medically necessary, right? Or is it just padding the pocket of the physician or clinician during the procedure? So I kind of understand the desire to subject some things to a prior authorization process, because it seems like if there's no scrutiny, our patients, our Medicare beneficiaries, being subjected to procedures and tests that, one, don't have very good evidence behind them, two, have side effects. Everything can have a side effect, and may ultimately do more harm than good, right? That's the question. And so that's what is happening here. And so I kind of understand the impetus of wanting to go to now have prior authorization with traditional Medicare. So I guess we'll see how it goes with the pilot. It'll start in January, last for 6 years, and again, I have mixed feelings. If it's not too onerous, if it really does prevent unnecessary treatments to be prescribed for Medicare beneficiaries, if it saves money and it doesn't delay care, then I think it would be a good thing. The jury, however, is still out. Thanks so much, everybody, for your time and attention. And until next time, this is Hesham Hasabala signing off on Healthcare Musings. Thank you for listening. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.